He always gives talks at the American Academy of Neurology, and he is considered the GOAT, the greatest of all time amongst all of the practice managers throughout the country. And I would like to introduce what I would consider to be the Michael Jordan of revenue cycle, Jose Rocha.
Oh, hi everyone. Thank you for doing this. Thank you for allowing me to be here. I actually have to say, I'm not usually nervous when I speak, but because I speak a lot for the AAN, but this is the first time that I'm speaking in my home with my doctors. So it's a little bit intimidating because I know everybody in the audience. This talk, the business of medicine. Actually, I used to teach at FIU, and I used to have 18 weeks to go over this. Then I started teaching at Nova, and they shortened it down to 8 weeks. Then we started doing a presentation for the residents and fellows, and it got shortened down to about an hour and a half or like 90 minutes presentation. And now today it's been shortened to 30 minutes. So I am going to try to do my best and keep this to 30 minutes so Dr. Corman doesn't call my attention. So let's go. And if you have any questions, we can definitely do this answer any questions at the end. Um, so first, the business of medicine. The core truth of healthcare. Healthcare is one of the only industries where you deliver the service first and negotiate the payment after. Revenue cycle lags 30 to 120 days, multiple payers, multiple rules, no price transparency at point of care. So it's one of the interesting things that we see in medicine. How medical practice actually makes money, revenue drivers. So, of course, volume, visits, procedures, infusion, payer mix, Medicare versus commercial versus Medicaid, and our contract rate. And then a part that I think a lot of people forget to do is cost structure. You can only see so many patients in a day. You can only have so many payers, and your contract rates are only going to be so good. At a certain level, you need to also look at the accounts payable, not only the accounts receivable, but the accounts payable. Clinical labor, the labor costs, the drug acquisitions, and overhead. All these different things. I'm one of those persons that if you're renting a copier or a printer in your office, I always get upset. One of the things I did here many years at the corporate office was I got rid of all the copiers and all the printers. And that was about 10 years ago, and somehow we've been able to survive without it. Um, the revenue cycle is the engine. Net collection rate is one of the values that we're going to be looking at. The denial rates, we'll be looking at that too, at these formulas. Days in ARs, and we'll look at some of the formulas for chart lags. Most practices that I go to, they don't have a revenue problem. They have a revenue cycle problem. Um, and that's something that I find it to be very true. Most doctors are working and seeing their maximum number of patients. There was a practice that many years ago, we didn't, when we started doing their revenue cycle went up by almost close to $1 million. Now, we didn't do, and the doctors didn't change anything. Same number of doctors, same number of practice, same everything. The only thing that was fixed was the revenue cycle problem. So payer strategies and negotiation, how payers, if understanding the people that are in this healthcare business. So if you don't understand how United Healthcare, Aetna, Cigna actually make money, then understanding their process also helps us understand how we can be influential in sharing some of that money. Understanding that they look at something called the medical cost ratio. Do you know what that formula is? Why payers deny, delay, and downcodes. I never see the payers as adversaries. They are businesses optimizing margins. This is what they do. And I just try to get with them so they can help, so we can work together on this. Service lines for a medical practice, critical for neurology. E&M visits, they have a low margin but high volume. You can see a lot of patients, but again, a doctor can only see so many patients in a given day. Diagnostics, EEG, EMG are usually margin drivers for a practice. Infusion, high revenue, but also very high risk. Where practices lose money, denials not appealed, underpayments not identified, poor scheduling, no-show rates, and bad contracts. I've seen this for so many years. Growth strategies, improve access, new patient flow. Now, when I say improve access, new patient flows, I want to remind everybody you can only see so many patients in a day. So what's the ways that we can do this? Well, telemedicine. There was an abstract recently published in the AAN, which basically said that there was no difference in treating a new patient or treating a new patient via telemedicine or via seeing them live. And it was interesting because it was actually quite a lot of patients in this study that they compared. So if you have a chance, go to the AAN and look up the study. But again, improved access means also responding to your patient portal messages and charging for them. This is a way of creating revenue. Adding ancillary services, EEG, infusion, imaging doesn't necessarily mean also an MRI. It could also mean TCDs, ultrasounds, different services. Optimizing provider templates. Always give to. I did a talk at the AA conference this past conference about 2 weeks ago. And I said, give to Rome what Rome wants. So put in your templates what the insurance company wants. Because if you don't, then you're going to be asked to do more work for them. And here's the problem. The people at the insurance company didn't go to medical school. So they do not understand the lingo, or they don't have medical literacy. They understand a few words here and there, but if you don't put it in a way they can understand, then you're going to get asked for more information when the information can be probably already there. And strategic hiring, APs and MDs. I was talking to a doctor today, and I was telling him how important it is for him at where he is in his stage right now to consider hiring an APP. Because it can help him alleviate in some of the work. He's reached that stage where what he's doing is the best and the most that he can do. So option one is you can try to go get another doctor, but in his area and community is probably not a good option. But getting an APP will shorten his wait time and also give him the ability to have a little bit more breathing time. Um, Regulatory and policy pressures. Every year we have to deal with Medicare physician fee schedule changes, telehealth rollbacks, value-based care model changes. Now, you don't control the policy, but it controls your revenue. So if you are not up on the policies or up on how these new changes are going to affect you, then you can be losing a lot of revenue. It's very important to understand that in 2026, uh, the government, CMS, and the payers are making a big focus on chronic services. So principal care management, chronic care management, the guide program. That's where a lot of the services or a lot of the focus in revenue is coming. So it's good to pay attention to what's going on with the policy. The future of the business of medicine, fee for service versus value-based care. This is something that, it's coming, it's here, it's knocking out our doors. And if we're not prepared to understand it, then it could it could put us in a really bad place. We can have all these superlative contracts, But if we're not showing the value-based care, if we're not showing the way the payers want to see value, then we can lose those superlative contracts. Vertical integration, this means like all the payers are now they own the pharmacies, they own the doctors, they own the clinics, and they're all starting to own all the ancillary services too. So that's something that you have to keep in mind. Site of care shift, hospital versus office. There is a reason why a lot of hospitals have been hiring physician groups and physician practices. They know this, they see it coming. And that's why we have one of the biggest competitors right now that we have are not any other medical practices, but are the hospitals offering these incredible salaries to young people that in reality they need it because they're in debt to coming out of medical school and residency with $400,000 in debt. So those hospital contracts are very, very lucrative. Um, Now, know the game or the game will play you. And I think this is very important and kind of funny to me. You wouldn't show up at a baseball game dressed in a hockey outfit, or you wouldn't show up for a football game dressed with basketball gear because you're going to get destroyed in both if you showed unprepared like that. So be ready. Now, my personal observation is medical passion is the deep purpose-driven commitment to patient care and improving lives, crucial for sustaining a medical career, preventing burnout, and providing high-quality care. It often stems from empathy, a desire to tackle complex challenges, and a commitment to service, acting as a key motivator in demanding field. I put this slide here because I am in awe of most of the physicians, if not all, the physicians that I work with. You guys have this passion and this deep purpose to help your patients, make the community better. You really try, even though the community is beating you at every turn. Your patients are not wanting to pay their deductibles. Your patients are picking the plans that are showing up at your office that have all these restrictions and all these processes. And I'll talk about that at the end. But it's incredible to see that after all the things that are happening, the hospital's putting restriction or hiring competition for you, but you are all still there trying to help your patients as best as you can. And for a business person, it's a behavior that yeah, I do admire, but at the same time, sometimes I just look at you, turn my head, and say things I can't say right now. So the mission of First Choice Neurology, and I took this from the website, is to improve the quality of neurology services while cost effectively providing those services to the communities we serve. So that is the mission. That's what this company was put for. Here are the payers and their mission: to help people live a healthier life and make the health system work better for everyone. That's a wonderful mission. Anybody knows whose mission that is? I know you guys can answer, so don't answer. But it's United Healthcare. Bring our hearts to every moment of your health. This one should be easy because their logo has actually a heart. That's Aetna. To be the partner of choice for improving the health, well-being, and peace of mind of those we served. That was Cigna. And my favorite payer, to be the leading innovator enabling healthy communities. Florida Blue, the only non-for-profit corporation out of all those there. They're also more profitable than any of the ones there. So with their mission and our mission, we should all be like holding hands and singing Kumbaya because we all seem to be saying the same thing. So here's a little thing, like I said before, when you write things in your reports, sometimes people don't understand it. You guys went to school, trained for 12, 13, 14 years to become neurologists, become professionals, and you have your medical literacy. So if I looked at this report, I can read it, I can read all the words, I can mispronounce a couple of them, but I can tell you I have no idea what this report is literally saying. I think it says something like the person has something with their joint, um, and their shoulder maybe. That's it. That's my understanding. But I assume that all of the people here can actually read this and understand this and have no problem. Read it in 2 seconds. Many years ago, I was in the middle of an audit for one of the doctors, and I had to call in one of our other doctors to help me kind of decipher this note. And this is one of our doctors who loves to dictate a lot of pages. Each of his visits might be 8 to 12 pages. So it was really funny because the nurse from Medicare and me were having a hard time like deciphering. And I'm saying the nurse, she was a nurse. I'm not clinical. The nurse was having a hard time. And we happened to call this physician in who came in, and he looked at the entire thing in less than 2 minutes, and he pointed out on page 3 where the MRI was being justified. It took me and the nurse were actually going over this for about half an hour before this I decided to call this other doctor in to help us. It took him no more than 2, 3 minutes to find it, and it was I five eight maybe 8 pages, and it took him no more than 3 minutes to find it. Now, this is from United Healthcare quarterly earnings report. It says United Healthcare's medical cost ratio was 83.9 for the first quarter of 2026. This means that, by the way, the first quarter ended in March 31st. So just to share that, down 90 basis points for the first quarter from the first quarter 2025. The operating cost ratio of 13.8 in the first quarter of 2026 compared to 12.4 in the first quarter of 2025, reflecting investment to drive improved consumer and care to providers' experience and a greater operating efficiency, as well as investment in its people and its community. This is part of their official earnings report that they put out at the end of the first quarter. Now, does any of you know how well you did the first quarter of your of 2026? Here's some financial literacy. UHC medical cost ratio was 83.9 for Q26, down 90 points from Q2025. What down 90 basis points means, 1 basis point equals 0.01%, 90 basis points equals 0.90%. So Q1 2025, Medicare 84.8, medical cost ratio, and 2026 medical cost ratio was 83.9. What actually changed? For every $100 in premium in 2025, $84.80 were spent on care. In 2026, $83.90 were spent on care. 90 cents less per $100 is being spent on medical costs. At the end of closing today, United Healthcare was worth $336 billion. So that's a lot of $100 that are being spent, that are being saved on care. What this signals is improved payer margins, lower medical cost ratio, higher retained earnings. So if you hold stock in United Healthcare, you did really good. And if you go look at their ticker symbol, they're up actually 397 today. So what could this be? It could be medical costs went down or premium revenue grew faster than costs. Possible drivers, common reasons to see this shift is tighter utilization management, more denials, out control, rate discipline with providers. Do you understand that rate discipline with providers really means down paying providers less? At the beginning of this year, we were approached by 3 payers to reduce our contracted rate. So better risk, mix and underwriting, meaning they got healthier patients that didn't need costs. Pharmacy control costs. This is always a big one. I have a saying of telling the payers that whenever they teach us how to treat MS with water, I will start giving them the best water that I can find. But at this point, we can only use the drugs that are on the formulary that they have approved. Now, lag in high cost claims, that just means timing issues. Some people were holding claims, but usually people don't do that during the first quarter because they're holding Medicare claims. So they don't hold their managed care claims because they're trying to get that money out in as fast as possible. So if you now understand that report, they said reflecting investment to drive improved consumer and care provider experiences, a greater operating efficiency, as well as investment in its people and the community it serves. They did that by paying for medical care less. Remember, the reasons this happened was tighter utilization management, which meant more denials, and auth controls, rate disciplines, which means paying the providers less, finding healthier people, pharmacy cost controls, or a lag in high cost claims. So the point of this is understanding how they use the language to say, hey, there's more profits, but that's because we invested in our patients. Now, medical cost ratio. The United used that thing to share with its shareholders. Do you know the medical cost ratio formula for your practice? Now, this will be shared with everybody, so you will have it and you can take some time. Incredibly speaking, you don't need calculus to do any of these formulas. You need elementary school. You need arithmetic. You don't even need algebra. These are the numbers that go into each component. The clinical costs, the provider compensation, the clinical staff, medical supplies, infusion drugs acquisitions, diagnostic costs, all the consumables for EMG. And you can do this for the entire practice, or you can do it individually for just EEGs in your practice. You want to know how much they cost. You're paying your technicians this much. You're paying your uh, 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 for that office or suite or location. So you can do it for lines of business within your own office. Denominator is, the net patient service revenue. So this formula will help you know what is really costing you to provide the care that you're providing in your office. Now, this second formula is your credit score. And not your credit score, but it's your practice credit score. So if you go right now to a bank and you try to get a loan, what they're going to do, if you're doing a personal loan, they're going to look at your FICO score, right? And that's your FICO score. That's how they determine what rate you're going to get. If you're in the 500s, you're going to get a horrible rate. If you're in the 800s, you're going to get an amazing rate. In a medical practice, they don't have medical FICO scores for medical practice. What they look at is your days in AR. So, and that graphs your total AR divided by your average daily charges. It's a simple calculation. Now, the benchmark in neurology is if you're 40 days or less, you're elite. 40 to 50 days, strong. 50 to 60 days, average. And 65 days, problems with denials, low follow-up, and payers delays. Now, days in AR equals the speed of cash. The lower it is, the faster the revenue cycle converts work into money, which is our goal. We want to convert all of the work that you're doing into money I tell the doctors this all the time. It's my money until it gets to the bank. Once it gets to the bank, spend it any way you want. I do not care. But while the money is in ECW, it's my money because I can feel personally responsible for it and I can have some interest in it. Once it gets to the bank, it's your money. Spend it however you want to spend it. Another formula is the net collection rate. So it's great that you have all this money, but are you collecting everything that you could collect? You know? So you build out $100,000, you collected $60,000, and you're happy, you know? And I see a lot of practice. I actually was talking to a practice in Texas today they bring in a lot of money. Um, and I was looking at some numbers, but I realized that their net collection rate was below 74%, which means they're missing hundreds of, actually probably millions of dollars that they're not collecting. So the net collection rate is how much of the money, of the allowed money you successfully collect. So our charges are inflated by 400% of Medicare, or 200% or 300%, depending on where you are. We build and we expect to collect the allowed amount. So out of the allowed amount that we bill to the payers, you successfully collected how much of that? A high NCR or a high net collection rate is anything between 96 and 100. You're collecting almost everything you should. There's minimal leakage. Um, Low NCR, it would anything below 95%, money is being lost somewhere, denials are not being worked, underpayments are not appealed, timely filing issues happen. So it's one of the things that I tell people. I can appeal most denials. I can't appeal a timely filing issue because that means there was never a claim originally, you know? So something very important to look at is your net. Are you collecting everything that you're supposed to collect? Now, this next formula is your denial rate, the percentage of claims that get denied on submission or processing. In this case, you will grab all your denial claims, divide them by the total claims, multiply them times 100, and you'll get your percentage. And here's the benchmark. If your denial rate is below 3%, it's excellent. 3 to 5% is healthy. 5 to 8 is concerning. And 8% or greater, you have operational problems. That's our denial rate for the first quarter of 2026. So it's 1.5%. So we're in the excellent part. Um, so denial rate, what it reveals about your practice. Front-end breakdowns. Biggest drivers, high denial rate usually means problems before the patient is ever seen. Eligibility not verified, missing or invalid referrals, prior auth not obtained. This is where most denials originate, in this front-end breakdown. Coding and documentation issues. Incorrect CPT ICD-10 pairings, levels of services not supported by E&M scrutiny, modifiers errors. The two most common modifiers in neurology are modifier 25 and modifier XS. If you don't know what modifier XS is, you are about 4 years behind. So something that you should look at. This is particularly relevant with pairs like Cigna and Aetna. Processes inefficiency, again, late submission, time filing denials, claims not scrubbed properly, poor charge capture in the workflow, revenue at risk not just being delayed. A denial is not just a delay, it's a revenue that may never be collected. Some get appealed. Only about 35 to 50% of claims get ever appealed. Some never get work. About 50 to 65% of claims never get appealed or worked. That's where PMM makes their money. When we go into a practice that all of a sudden was generating $100,000 and now is generating 150, that's not because we made the doctors work better or we got more patients inside the office. All we did was work the claims that were never worked. That's it. And there's a lot. I mean, 50 to 60% of claims are usually never worked. So I have a lot to work with whenever we work in a practice to make us look good because all I have to do is work what hasn't been worked. Um, some get overturned. About 60 to 80% claims that are appealed on a first try get overturned, but only 5 to 15% of denied claims ever reach a second level of appeal. That means people are leaving 95 to 85% of their claims that got denied, never going to a second appeal. And some claims will get written off. So that revenue at risk is not just being delayed, it's just not being received at all. Payer behaviors. When you break down the denial rate by payers, you'll identify patterns with United Healthcare. Algorithm edits, Aetna, auth and medical necessity, Florida Blue, policy-driven edits. If by knowing these things, we are able to strategize with our EHR to better prevent those edits. So we can have front-end edits that keeps our denials at 1.3, 1.5, 1.8, instead of having denials over and over things like these algorithm edits or this auth medical necessity. An algorithm edit, for example, would be that United Healthcare doesn't accept modifier XS. They're still using modifier 59. So this is one of the things that is understanding how your payers work, understanding their behavior helps to keep the denial rates low. Now, other formulas that should be kept in mind are called conversion rates. How many of the appointments are being booked? People are calling the office. Are you getting appointments for this? No-show rate, probably one of the most underrated statistics. No-show rate is one of the ones that I would say it's very, 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 very much dependent on the provider. Okay? It's your house. If you tolerate bad behavior in your house, people will disrespect your house. I many years ago, and I learned this from one of our providers. He has a zero tolerance for no-shows. Like zero. You get one time. Everybody gets one time forgiven. After that, you get discharged from the practice. And let me tell you, his no-show rate is non-existent. His patients always pay their co-payments. His patients have no problems with balances. His patients are never surprised about anything. His patients come knowing they're going to a serious practice with serious expectations. And they know that the doctor is going to hold himself accountable to a high medical standard of practice, but he's also holding his patients accountable. And to me, it was at first I thought he was being really harsh, but over the years he has taught me that his method works. His method works for it's effective, and it not only has it improved his no-show rate, it actually, like I said, his patients all pay. They all come ready to, nobody shows up and say, oh, I didn't know I had to pay. Oh, I didn't know how to balance from last time. No, they come ready and they're prepared. The yield per CPT. So how much is each CPT allowing you? Is it better to build for, the extended EEG versus the regular EEG? And we had a provider that actually it was not worth it because the technician was charging him a little bit more. So he was actually bringing less money in on the extended than he was doing on the regulars, over the days spent, because he was having to pay the technician more. Charge lag. So charge lag data service versus charge entry. So one of the things I was asked recently is how long does it take to take a hospital billing in? And I said, well, if they use the eClinical mobile, it usually takes about 1 to 2 days. Sometimes it gets done on the same day that it's entered. Depending, if the doctor does it at 3 o'clock in the afternoon, then most likely will be done next day. If it's done paper or manual, it might take a week to get in. So still, the goal is always to be within 3 to 5 days for charge lag and charge entry. Cost per encounter. So what's the total operating cost and the total visits? Cost per visit. What does it take? What does it cost to provide these services in our office? These are all things that are very important um, for for um, for a practice to know. And the core AR formula. AR is a specific aging bucket. Total AR, what percentage is it? So what percentage of RAR it's being aged in a certain bucket? Okay, payers. Payers are not the adversaries. They are business optimizing margin. Their businesses optimizing margins. Companies like United Healthcare, Aetna, Cigna, and have a simple financial goal: profit. What's their goal? Profit. Premiums collected minus medical costs minus operating costs. When I talk to United, Cigna, AvMed, Aetna, whenever I talk to them, I'm never thinking that their goal is whatever it says on that mission that to provide care. No, I know they want profit. They have shareholders that are going to hold these people accountable. If you see them as adversaries, you react emotionally. They're denying everything. They're being difficult. If you see them as a business, you act strategically. They're protecting their margin. Where is my leverage? So I go in there thinking they're just trying to protect their margin. Where is my leverage? What do I have? And we have a lot of leverage. Instead of how do I fight the payer, you ask, what do I have that they need? We have access. We cover multiple hospitals, multiple locations. We have a big geographic thing. Subspecialties. We have epilepsy, headache specialists, movement disorders, um, ancillary services, EEG, infusion. When Cigna wanted to increase their infusions and move them out of certain areas, they came to us and asked us for assistance. Volume, we see about 1,600 patients a day. That is leverage. So when you have access like this, when you have these many subspecialties, we can affect the quarterly reports for any of the local payers in Florida. And we have sometimes because they've have personally asked me to do it. you know? So, and that just means they owe me a favor today, and later on I'll cash in on that favor. But it's if you want to strategize and make a change really quickly, you can go to 50 neurology practices and tell them all to make these changes, or you can go to one big one and in less than a quarter, it can reduce your medication costs. We actually did that once with the MSOs from Humana when we were with them. They came to us, we talked about certain drugs, and within a quarter, we affected their drug costs. Well, mm. So payer tactics versus the provider counter strategy. This is what the payers are doing and what we can do against it. Payers are not against you. They're optimizing their financial model. Your job is to optimize yours and negotiate when they intersect. United Healthcare is an algorithm-driven E&M coding, broad opposed payment audits, tied utilization management, and payment delays via review cycle. Aetna, heavy prior authorization requirements, frequent medical necessity denials, narrow network strategies, stepped therapy enforcements. Cigna, outlier for providers, targeting coding utilization, bundling and modifier scrutiny, behavioral health integration controls, predictive analytic for cost containment. All of this is what they're doing. And what can we do? Well, we can do data-driven defense, tracked our rates, our denial rates, our AR by payers, build payer scorecards, identify underpayments systematically. If you can measure it, you can fight it. So if I can't see what United Healthcare is doing, I can't fight it. If I cannot measure or have a scorecard or say, okay, they're doing this, we need to do this, and we need to prevent this. Uh, it's very important to keep track of what is going on in and how the payers are processing your claims. Documentation and coding precision, standardized E&M level education, audit internally before the payer does, defend with CMS and AMA guidelines. We do that all the time. This is part of our culture and how we do things. Sometimes, doctors get upset because we ask them to change something in the note. We are never asking them because of us. We are asking them because we know that there is somebody at United that will make a big deal about it, or somebody at Aetna that would make a big deal about it. You know, denial escalation disciplines. This is one thing that I have to say. Appeal denials, use of second level appeal strategically, track appeal success rates. This is very important to have, a structure of how to do the appeals and holding people accountable for those appeals being done. Most providers stop at level one and never go for the second appeal because they're concerned, they're scared. I don't know of what, but they should always go to the final appeal. Now, service line leverage, highlight infusion access, EEG diagnostics, subspecialties, all of that. It's something that you can work with the payers, and we strategize and use that. Um, we don't have to wait hours or, days or weeks or months to have somebody have an EEG. We can do that a lot quicker. Movement disorder specialists or the epilepsy specialists, we can get those appointments really quickly too. So it's something that where the service line can be a leverage. Ambulatory services, we can provide them, ambulatory EEGs, we can provide them really quickly. Contracting strategies, set rate floors, percentage of Medicare. Like I have a rate floor that I have to follow that it's set by the FCM board. And when in payer tells me that they have offered us something, if it's below that threshold, then I go back, I tell them no. If it's above that threshold, then the negotiations can begin. Refuse unsustainable contracts. We have done that in the past, where a contract is just the cost of providing the care would be more expensive than seeing all those patients. And I see so many times where a doctor thinks that as long as there's a patient in the room, I'm making money. No, sometimes you're paying to see that patient. And the most common specialty that I see that in is the headache specialist. A lot of times they're actually paying to administer to that patient the toxin or whatever drug, the CGRP. So it's very important to understand to refuse unsustainable contracts. Use volume plus geographic coverage as a leverage. It's okay to walk away. One of my mentors once taught me that if you go into a negotiation not ready to walk away, then you've already lost. And I've always go into every negotiation knowing that the option might be walking away. Many years ago, I think wisely, and I had nothing to do with this, but many years wisely, FCN board walked away from their Blue Cross Blue Shield contract. They were without Blue Cross Blue Shield for about 10 years, and today hold one of the highest paying Blue Cross Blue Shield contracts. But that was because they decided to walk away. And over those 10 years, First Choice Neurology grew. At the time that they walked away, I think they had 32 care centers or 31. And by the time they came back, which was in 2024, we had 63 care centers, so almost 30 more care centers than we had. So it is okay to walk away, you know. Operational excellence, reduced chart lags, days in AR, no-show rate, and AI implementation. AI implementation has resulted in an 8% employee force at the corporate office. At the end of last year, we had 82 employees, and I think we have 78 now. So that's improving in the right way. All these appeals before artificial intelligence, most of the appeals have to be had second level appeals or more complicated appeals, all had to go through my desk. Now I can tell you that I am probably looking at 1 to 2 appeals a week. And I compared to 2 years ago before the artificial intelligence was available to us. Most of those appeals are being done by the staff. They are excellent. At first I was concerned, but now they're even better than anything I would do. And it's an efficiency in equals negotiating power. So it has saved us. It has allowed for me to have more free time to deal in other areas because now the team, and they're more empowered to do it, and they're able to tweak those appeals very, very good. I mean, they're doing an excellent job on that. So payer optimizing margins, providers must optimize their strategy. Now, um, this is my last slide. Like I said, they told me I had to do this in half an hour. So what is capitalist? What's a capitalist economic? A capitalist economic is an economic system where private individuals or business own the means of production and operate the profit. That's first choice. The production and practices of goods and services are determined by the free market. That's your patients based on supply and demand. So whenever you guys complain about the healthcare system, it is not United Healthcare, it is not Cigna, it is not AFMIP, Blue Cross, or any of your payers' fault. It is your patient who is responsible for this. If the patient wasn't buying the plan, then, and every time you try to solve the problem of the patient and you put yourself in between the payer and the patient, you are not helping your case. You are just not making the patient realize that the plan he picked is not providing the adequate care that he needs. And I'll finish with this story. Recently, one of our doctors called me and said, "I need this patient to have this infusion." And I said, "Sure, okay, I'll see what's going on." It turned out that the patient was in collections. So you guys can continue to see a patient if a patient is in collections. But if it's an ancillary service, we don't see them until they pay their collection balance. So and the balance, the balance was not from that care center. It belonged to 2 other care centers. So I told the provider, listen, you can't ask me to write it off because it's not your balance. And second of all, we can't see them until the balance pay off. And he said, well, you contact the family and tell them to and offer them a payment plan. And I said, sure, we'll do. That same day, we offered the family a payment plan. The family declined, automatically said no. And I said, okay, no problem. There he goes. And I don't know how they're going to get their infusion or not. But this doctor was so worried and concerned about getting the patient's infusion. By the way, the balance was on 3 claims. One was 55, one was 45, and one was $700, which we were willing to give them a discount on the 700, of even 50%, and they still said no. Okay. So when a patient is not willing to pay the balance, and this is where I go back to where I put medical passion, how you guys see all these different things. and how this doctor was really just caring about his patient. And I don't, I admire him. I'm glad that's the kind of doctor I want to have. But in the end, you have to realize that this is a business. And if you don't pay attention to the business, you will be used and abused. So I have a couple of questions here that were sent through the chat, so I'm going to answer it now. But like we said, uh, so first, what's FCN's days in AR? We're at somewhere between of 0 to 30 days is about 60%, 65%, which puts us in the excellent category. Depending on which services you are. Infusion, for example, is 90% in the 0 to 30 days. First choice as overall is 0 to 30 days is about 65% of our ARs in 0 to 30 days. Um, What's the days in AR? Yes, 20, it's 24 now. It's 24. Earlier you mentioned that three payers asked for a reduction in our rates. Did we? No, we did not. We did not do a reduction in rate. What is modifier XS? Modifier XS was implemented to separate from modifier 59. So basically, what modifier says is that it's used in medical billing to clarify that a procedure was done in a separate structure. Okay. So when you're doing EMGs, sometimes and you do, for example, the right leg and the left and the right arm, if you put RT only, it creates a problem because the computers and the way they see it. So you have to put XS to say this is a different structure, and then you can put RT, and then the other one just requires XS. What is FCN next net collection rate? Right now it's 98.4. What makes or why are infusions a high risk for practice? Because if you do not manage it properly, the problem with and I did a talk actually at the AAN conference on infusion and infusion rollout, and to me, the most important person in the infusion process is not the doctor, is not the nurse, is the purchasing manager. The purchasing manager has to look at the price of the drug, which changes quarterly, and has to know how much drug to buy. And sometimes, for example, at the end of the year, we buy close to $1 million, if not $1 million worth of Botox. We do this because we're buying it at last year's prices, with last year's discounts, and then in the beginning of the year, we use that for the first quarter. Now we're getting it paid at this thing. So it's usually we're making anywhere from $5 to $8 on a vial. At the beginning of the year, we actually make anywhere between $12 to $15 on a vial because we were able to see our purchasing and calculate how much drugs we will need. Sometimes we have to buy with the drugs is not only looking at how much we're getting paid, but what the rebates are, what the discounts are. And all of that requires somebody actually paying close attention to that. Because you can have 100, you can be given a drug and you can be losing money on that drug. Like for example, for Vyepti for a long time was a losing drug. It cost more. For last year, for the entire first 2 quarters of 2025, it costs more to give Botox than it paid. So it's very important to keep that in mind when you're doing infusions. Are the returns for infusion and MRI prominent? If not, is it worth it to get into the infusion MRI business if the returns are not significant? The returns on anything can be significant, but like any business, the first year is low, and you make your profits on years 2, 3, and 4, 5, and moving forward. once you paid for the overhead and setup of doing the beginning, most of the services. But yes, infusion is very profitable. Do you want to know how you know if something in medicine is profitable? Very simple. See how many non-medical doctors are doing it. You want to see who runs 3T MRI, who runs DPI, who runs all the MRI facilities. They're not owned by medical people. So is MRI a profitable business? Yeah, it could be. Is infusion a profitable business? You want to know how many freestanding infusion facilities exist? How many nurse practitioners are opening their own thing to do infusion? Yeah, it is very profitable. So you ever want to know if a business line in medicine is profitable? Look how many non-physicians are opening that business, and that will tell you. DME, very profitable. That's why a lot of it is, has a lot of non-physician owners.
Thank you, Jose. That was excellent, and I think we all learned a lot. Um, Though, again, this was videoed, so it'll be available on our website, the First Choice Neurology website, and the subsequent ones also. So if you happen to miss one, you can always go back and see it. The next one will be next month, the last Wednesday of the month, and it'll be on acid protection. And again, the one in June will be on pension plans and all the different types of pension plans and the good, the bad, and the ugly. Um, the it is possible that no, not possible. It is probable that we will have visit the medicine this particular topic, but look at it from a different point of view. So obviously, half an hour to an hour is not enough to cover everything, but it's a start. And again, thank you so much, Jose, and thank you for everyone who participated. And if you have any particular topics, please send them to Jose or Lanny or myself, and we'll try to include it into the series.
Thank you. Thank you, everybody, by the way. It
Thank
was
you
a
and good night.
privilege. Good night.
Take care. Thank.